Dr. Doc's here to give us an overview of vision disorders that happen after traumatic brain injury. And if you want to learn more or you've got a medical issue, of course, you're going to go to a qualified optometrist like Dr. Doc. So without further ado, I'll let Dr. Doc start her lecture. I'll say a few things about Dr. Doc. She's a wonderful neuro-optometrist with a very high level of training. And she works extensively with the traumatic brain injury population clinically. So very excited to for Dr. Doc to share her knowledge today.
All right, great. So, thanks for the introduction, Dr. Batson. So I'm going to be talking about introduction to traumatic brain injury related visual disorders. So let's go ahead and get started. First, I want to talk about what are kind of the key components of the visual system. So hopefully everyone knows about visual acuity, that is 20/20 vision. How well can you see? There's your visual fields, how much can you see, your peripheral vision and things like that. There's also color vision, that's pretty self-explanatory. And then you have all these other things, your binocular vision, you have two eyes, you need to somehow get them to coordinate with each other. Your accommodative system, which is how your eyes focus at different points. Ocular motility, how do your eyes move from point to point? Your visual motor integration, how does your visual system tell your body how to move in reaction to something that it sees? And then visual information processing, how do we make sense of everything that's going on? So you can see this picture here is kind of just a very simplified representation to show that the visual system is spread all throughout the brain. And there's about 40–50% of your brain dedicated to some sort of visual process. And so you can imagine that there's a very high likelihood that if you have a traumatic brain injury, there's something that's going to go wrong with your visual system. And this is also to remind us that even though we have something in the brain called the visual cortex, which is that occipital lobe, that doesn't mean that vision happens only in one area. So again, all throughout the brain. So things that you have probably heard about in brain injuries, these are things that tend to happen in more severe brain injuries, cranial nerve palsies. The main ones are going to be cranial nerve 3, 4, and 6. Those ones control your extraocular muscles. And visual field defects, those are homonymous hemianopsias and homonymous quadrantenopsias. So that's where on each eye, one side of the visual field is essentially gone. And so these things are fairly easy to catch, if you will. Most people are trained to find them. If you're having them follow a target and one eye just stops and doesn't move, they probably have some sort of cranial nerve palsy. And if they just can't see something in their visual field, then again, they may have a visual field defect. Again, testing for these are usually pretty straightforward and people are not really going to miss them. So we're not going to spend too much time on these things here. So for a vision disorder in a TBI, most TBIs, about 80% of TBIs are what we call a mild TBI or concussion. And so most of the time you're not going to be seeing those nerve palsies or the visual field cuts. But up to about 85% of people who have some sort of TBI also have some sort of visual disturbance. And so very, very common. And the most common thing that you're going to see is probably a convergence insufficiency. The next most common thing that you'll probably see is an oculomotor dysfunction, so some issues with how people are moving and coordinating their eyes. All right, so the classic presentation of someone who has a visual disorder after a TBI is something called post-trauma vision syndrome. And these symptoms are the ones that you're most likely to see. They may have double vision, they may have blurry vision, headaches, light, screen, and motion sensitivity. They might feel like objects appear to move or jump or disappear on them. Poor concentration and attention, kind of that brain fog, issues with reading and things like that. They might have kind of more of like an intense stare. A lot of people will also describe an out-of-body sensation where they feel kind of detached or like a spectator in their own life. nausea, dizziness, and difficulty in crowded places. Now, some of you might not have thought of this stuff as being related to the visual system, so hopefully at the end of this lecture, you will know why those things are happening. And so the typical findings that we're going to see, again, convergence insufficiency, that's one of the most common things. And so this is kind of the classic presentation of someone who has had a brain injury. And most of the time, we're going to see some sort of exo, which is an outward eye posture. They're probably going to have an accommodative insufficiency, convergence insufficiency, a low blink rate leading to dry eyes and that staring behavior that I mentioned, spatial disorientation. So they're going to have issues. With depth perception, they might feel kind of lost in space. Again, that out of body sensation. They're going to have issues with their fixation, pursuit, and saccades, so their ocular motility. And they're also going to have issues with their peripheral vision, not to the point of having a field cut, but they will describe tunnel vision. They'll feel like, again, difficulty in crowds because there's more stuff in the periphery. And things like that. So even though this is the classic presentation, there are, of course, lots of variabilities on the findings, but this is the most common presentation. So for someone who's not an optometrist, the most easy way for you to figure out if this patient is having those symptoms or needs a referral is going to be this survey here. And this is called the Brain Injury Vision Symptom Survey, or the BIVSS. And it's a really good screening tool. It's also a really good way for you to demonstrate to the patient, hey, do you have these symptoms? And showing them that it might not all just be about how clearly they can see and things like that. And so it's 2 pages, and if they have a score of 32 or greater, that usually means that they're going to need a referral. If they have anything marked off as a 3 or 4 in the peripheral vision column, which you can see on the second page here, that is also cause for a referral, even if that's kind of the only thing that they check off, because those are just very highly associated with people having some sort of vision dysfunction. This is a book called The Neurosensory Disorders and Mild Traumatic Brain Injury. I'm going to highlight a chapter called The Vision Disorders and Mild Traumatic Brain Injury. If you have access to this book, it's a really good summary of, all the things that I'm going to be talking about essentially. And this one is written by 2 doctors, Dr. Eric Sigman and Dr. Patrick Quaid. Dr. Sigman is a neuro-ophthalmologist who was previously at Johns Hopkins and founded their essentially their vision clinic for TBI. And he emphasizes that these vision symptoms and visual findings are so common that we need to make sure that we're doing testing. A standard eye exam is usually not going to pick up on these things. And if you're not doing the testing, then just because your regular eye exam is normal doesn't mean that there's nothing wrong with you. And that can also impact other areas of rehabilitation because the visual system is involved in so many different things. So this is highlighting those differences in a kind of a standard eye exam versus a neuro-optometric evaluation, which is looking for those things that issues that people are going to have after a concussion. So in a standard eye exam, you're going to check visual acuity, reading the eye chart, how clearly can you see. You're going to check your extraocular muscles, visual field, and pupils, and that those 2 things are going to look at the cranial nerve 2, the optic nerve 3, 4, and 6 for the extraocular muscles, and check and see if those are intact. Refraction is determination of your excuse me, a determination of your glasses prescription. Usually the goal of a standard eye exam is to get you to see as clearly as possible, which is not always the goal that you're going to, have for a TBI patient, but that's, is going to work for most of the population. Sometimes they will also do an NPC, which is near point of convergence, and a quick check of phorias, and then they're going to look at the ocular health, making sure everything is physically healthy. So this is a good starting point, and it's of course very important for us to check and see, do they need a pair of glasses? Some people just are walking around without any glasses at all, and they could benefit from a prescription. We also want to know, is the eye physically healthy? Because if it's not physically healthy, that's going to be the first thing to take care of. So again, just because the patient passes this standard eye exam, if they're still having issues, that are kind of falling into those symptoms that I had mentioned before, you want to refer them for a neuro-optometric evaluation. And you can see there's a lot more stuff involved. So visual acuity, again, we still want to know how clearly the patient can see. Dynamic visual acuity is where you're going to have them looking at the eye chart and then shaking their head with, kind of the 2 cycles per second, like a VOR, and checking to see if their vision decreases. Um, I'm also looking to see, does it make them nauseous or sick or anything like that? And that would, of course, indicate an issue with their vestibular ocular reflex. Still checking UM's pupils and visual field refraction. And so when I'm checking a glasses prescription, I want them to see clearly enough, but I also want to see if I can make their eyes work a little bit more efficiently. And so that's, kind of the difference in goals with prescription. It's not always just one single number that everyone has. Prism and tint evaluation, seeing again if we can get their eyes to work a little bit more efficiently with that. We'll talk about that stuff a little bit more later. And then lots of different tests, checking their eye alignment, checking their eye tracking, checking their focusing system and their fusional divergences and things like that. And so just a lot of different things to look at how they're functioning versus just kind of can they see clearly, yes or no, and whether or not their eyes are physically healthy. Okay, so then let's look more about what am I testing for. So a binocular vision disorder is essentially your two eyes are not working together as they should. So the first main category, strabismus, that is where when both eyes are open, you have one eye turning either in, that's an esotropia, out is an exotropia, up or down is a hyper or hypotropia. And a strabismus can be constant. It can be intermittent, where sometimes their eyes are lining up, sometimes it's turning, and then it can be one eye only doing that. And it can also be alternating, where their eyes kind of switch off which one is looking at something. Then you're going to have either convergence or divergence dysfunctions. And so these are kind of considered more mild cases, if you will, but the symptoms are often just as severe. And so convergence dysfunction, you can have insufficiency or excess, and same thing with divergence, you can have a divergence insufficiency or excess. And so um, in insufficiency, that's pretty straightforward. They just don't have enough convergence or divergence. And excess doesn't mean that they have too much of it or that they're great at it. It means that they kind of get stuck in a position. So they're doing too much divergence and they just maybe don't know how to get out of it. And so, with all of these binocular vision dysfunctions, you can have similar findings. So, we're of course going to be looking to see what direction are their eyes misaligned and things like that. But then, pretty much all of them, they're going to have impaired stereopsis, which is a measurement of how finely can you tell the difference between the disparity of two different objects. And we use that to kind of extrapolate of how good their depth perception might be. You might have suppression, which is where the brain recognizes I have a hard time coordinating my two eyes, and so let me just ignore one eye, problem solved. Now I just have to deal with one. Reduced fusional divergences, so that they are not able to adequately converge or diverge in some way. And then a receded NPC, and then very common with TBI patients is that they might have discomfort with NPC. So with all of the testing that I do, I tell people that you should have no pain or discomfort and it should be pretty easy. For TBI patients, they may potentially have normal numbers when they're doing stuff, but you just see how hard they're working. They might be flinching on you. They might feel nauseous after they do it. And so that would also be an abnormal test. Now, for NPC, I know a lot of people are doing that nowadays, which is really great. But the important thing to remember is that a receded NPC does not necessarily mean a convergence insufficiency. You can have someone with a convergence excess or an esotropia, which is where your eyes are crossing too much. And you can have a receded MPC still. And so, if you are only testing the MPC and not really figuring out what else is going on with the patient, if you work on convergence, you can actually make that patient worse. So, it's really important that you are getting that patient diagnosed appropriately and figure out what exactly is going on with their whole visual system. And again, also, these binocular vision disorders have a lot of overlapping symptoms. So a lot of them are going to have headaches, and they're going to have maybe double vision if they're not suppressing, or blurred vision. Sometimes it's hard for people to distinguish between the two if it's very subtle. Eye strain, poor depth perception related to that reduced stereopsis, dizziness, and balance issues. So think of it as your two eyes, they need to point at the same thing. It needs to be stable. And then you can kind of get them to move and jump around and do your head shaking for the VOR and things like that. If your eyes are having a hard time staying lined up at the same thing, they're kind of drifting off and things like that. If you try to add head move into it or motion into it, things are not going to look very good and it's not going to feel very good. And so people can have a lot of dizziness and balance issues if their eyes are just not very stable. And of course, reading difficulties, poor concentration, losing your place, drowsiness, being sleepy while you're reading is another big thing, and reduced retention of reading material, people kind of feeling like they read something, they saw it clearly, but they just have no idea what they read, and so they kind of have to keep repeating. And this right here is kind of just a little example of what double vision looks like. So double vision does not have to be two distinct things. Double vision essentially just means not single vision. And so you can see that this is not really a fun experience to be looking at. It's kind of a little bit nauseating. And this is a reading example, but imagine this also happening when you're trying to look at anything else. So not really fun there. Not everyone, again, is going to have double vision. They may not have it to this extent. If they're not seeing double vision and we find a very significant binocular vision disorder, they could be suppressing. And that, in some sense, is worse for the patient because they feel kind of all the ick feelings still, but they don't know why they're having it because they don't have that cue of like, oh, hey, something's wrong with my vision. And then as you're looking at this, you can notice that the smaller print is kind of a disaster. The larger print is not too bad, and the pictures are also not too bad. And so, a lot of patients will say, oh, I've started enlarging the print, or I find that if I have like a really dense document, I do worse versus if I just read like short emails or something like that. And this is part of the reason why is that the more stuff you have, the more potential it has to kind of mess up. And so for a lot of patients, if they haven't already started increasing their font size, I will say, hey, try to do this so that you can at least get through what you need to do. And they also might feel like, watching videos or something is a little bit easier than sitting down and reading a book. Okay, so moving on, then the next thing to talk about is fixation. So fixation is a sustained visual attention on a target. You can see the picture over here. There's my eye tracker results. On the bottom, you've got normal, where there's essentially a little black dot in the middle, which is the representing the patient's target, and then there's little teeny tiny dots around it where the patient was just looking at one thing and staying relatively stable. And then above it, you see an example of an abnormal fixation where there's just kind of a bunch of green and dark green splotches around those central dots, and that's where the patient was fixating. You can see there's a wider spread, so this patient had abnormal static fixation where they're just looking at a single target. And the vestibular ocular reflex is essentially a fixation while your head is moving. And so your extraocular muscles and your semicircular canals need to communicate and say, I am going to do the equal but opposite action as you're moving your head. And that communication needs to happen one-to-one, as we're talking about. If they have a binocular vision dysfunction, that's going to create a lag between the two eyes. The visual system is not going to be able to work efficiently, and that's going to create a lag in the communication to the semicircular canals, and they're going to feel awful when they're doing that, even though their vestibular system might be completely intact. And then the other eye movements, you've got your saccades. Those are rapid eye jumps that you typically use for reading and scanning. You have pursuits that are used for kind of following a moving object. And you can see those eye tracker results again, normal on the bottom, abnormal on the top. So on the normal saccades over on the left-hand side, you've got the lines going side to side between those little dots, which are the patient's targets, and the test stimulus is that there's a dot moving side to side and kind of jumping back and forth from right to left. The patient is asked to make that jumping eye movement and just follow it side to side. And so those lines should be relatively straight across. And then if you can see that little tiny graph going up and down, that's telling me what their eyes are doing, and it should look pretty much like that, where it's just little rectangles going up and down. On the top one, you can see that there's a lot of extra stuff happening with the eyes, and those little rectangles are very irregular, and so it's showing me that their eyes are kind of just jumping, maybe making a bunch of little small movements to get there versus just kind of a nice jump directly to where they want to go. And then on the right-hand side, you have your pursuits. Again, on the bottom, that is normal. So you've got that line going smoothly across. And then right below it, you see that kind of little sinusoidal type thing going up and down. That's a pretty normal one. And then on the top one, you see there's lots of extra movement, and there's kind of just little extra notches in that nice smooth wave that indicate that their eyes were jumping rather than falling smoothly across. So symptoms, you're going to have kind of objects disappearing or jumping if you're trying to follow because their eyes are skipping and not really following smoothly. You're going to have issues with reading, skipping words, losing your place, replacing words with kind of similar looking or sounding ones, rereading, slower reading speed, and poor retention are all very common. And as I'd mentioned, issues with dizziness and balance because of effects, to the VOR and communicating with the vestibular system. Accommodative dysfunction. So accommodation is the ability for the eyes to shift focus near and far and back and forth. Unfortunately, this does naturally decline with age. And so if you are under the age of 40 and you have issues with your focusing system, we're typically going to label you as an accommodative insufficiency. If you are above the age of 40 and you need reading glasses because your accommodative system is no longer keeping up. That's something called presbyopia, which is again kind of a normal type of thing. You have accommodative excess. Again, this is going to be usually someone typically under the age of 40, and remember, excess doesn't always mean that they're good at it or they have too much of accommodation. It just means that their accommodation gets stuck, and they will typically have blurry vision, fluctuating vision, headaches, the same thing with accommodative insufficiency. You can see that an accommodative dysfunction is pretty common. About 20 to 50% of the um, patients that they looked at between the ages of 11 to 17 had some sort of accommodative dysfunction. One thing to keep in mind, though, is that you will often come across those patients who are in their 40s, 50s, or something like that, and they will swear, I did not need reading glasses, or I very rarely needed my reading glasses before I had my injury. And you can absolutely have people in that age range who had kind of above average capability. Maybe they didn't need reading glasses or they needed them very rarely. And we know the accommodation accommodative system is affected after an injury. So those patients may now just be age appropriate with their visual findings and needing reading glasses, which we would expect at their age, but for them, it's a very stark contrast. And it's important to recognize and let them know that, like, hey, yes, I know you didn't need them beforehand. Your focusing system gets impacted with a TBI. I know it's a change, but unfortunately, this is kind of a typical thing that we expect. So acknowledging that they did have a change, but kind of there's not really much you can do about that particular part, unfortunately, is really good for them. All right, so then the pupil, that is the opening of the eye, the black part, lets in light, and the iris, the colored part of your eye, that is going to dilate or constrict to regulate light levels for you. If you had an injury that involved direct trauma to the eye, you could have changes in pupil size or shape. But for most mild TBIs, that's not going to happen. You could have an efferent pupillary defect, which is where one eye is going to dilate abnormally in response to light. That was only found to be present in about 2% of TBI. So again, not super common, but that's why we check pupils with patients. And an APD represents unilateral peripheral damage in the pupillary pathway. So that's important to pick up if it's present, but not super common. The more common things you're going to see in an MTBI is for adults, they found kind of a slower average constriction and dilation velocity for that pupil. So that means that they're going to be adapting to light changes in light a little bit more slowly, which can lead to some light sensitivity. They found some other changes to the pupil, but that was a little bit inconsistent across the studies. So the constriction and dilation velocity was the most consistent. Interesting enough, in adolescents, they found that the response was opposite from adults. And so they found that those younger kids actually had a faster constriction and dilation velocity. And one theory they had was that adolescents usually have a larger pupil size compared to adults. And so that might let in more light and kind of give that faster reaction. But again, that's just kind of a proposed theory. So definitely more research is needed in that area. So central peripheral processing and TBI, for me, this is kind of one of the more important things that I see going wrong in my patients is that they become very hyper-focused in their central vision. And so if you think about, the body and brain are essentially under stress, and what happens when you go under stress, you tunnel your vision. And just think about your central vision is considered to be the central, say, 10 to 20 degrees of your visual field right here. And then all the rest of that is your peripheral vision. So you have way more peripheral vision compared to central vision, but you have a lot more machinery, if you will, dedicated to the central vision compared to the peripheral vision. So you have the ventral and dorsal stream. The ventral stream processes the central vision with the P cells. For the retina, there's about a million P cells compared to the dorsal stream and the M cells. Those are in the periphery of your eye. There's only about 200,000 of those. And so the theory of why those are maybe affected more in TBI is that there's just fewer of them. But those M cells, they process that peripheral vision and they also process motion and luminance detection. So for patients who have issues, with their central peripheral processing. They're going to have that tunnel vision. They may not be aware of it. They might just feel like they're a little bit more clumsy, which could be from the reduced depth perception also, but they kind of feel like things jump out at them a little bit more. They're a little bit more startled by stuff. That photosensitivity and visual motion hypersensitivity. Where again, the M cells are not really processing motion and light quite as well as they should. So, talking a little bit more about photosensitivity, because that is so common, about 50% of those with TBI are going to report some sort of light sensitivity, and compared to only about 10% of the general population. A couple of different causes. I don't think we have a really good pathway nailed down for this right now, but the slowed light adaptation for those pupillary changes that we were talking about, that's definitely going to contribute. They're also finding that light is going to activate the brainstem trigeminal nerve pain receptors, and you have the first branch of the trigeminal nerve is the ophthalmic branch that deals with the pain receptors to some parts of the eye, and so those get affected with light after an injury. And then you also have pain receptors from cranial nerves 3, 4, and 6, those extraocular muscles, and those are often activated too because the patient is just putting in extra effort. You might hear people have pain with eye movement and things like that, and they're straining more for binocular vision. I have definitely had patients where, they have terrible light sensitivity, they have a binocular vision dysfunction. We fix that, and their light sensitivity improves quite a bit. So it's definitely related to that. And then that visual motion hypersensitivity that we're talking about. So this is a abnormal sensitivity to visual motion. So people are going to have issues with screens, especially scrolling on screens can be very bothersome. Watching TV or movies, especially kind of more like action movies. Issues in crowded environments, the very classic issue that TBI patients are going to have is going into a grocery store. They kind of get bombarded with those fluorescent lights and moving stuff, lots of clutter in their periphery, and just it's kind of a very unpleasant experience for them. And also riding in a car is very bothersome to them. Some people are going to have kind of just a vague discomfort with motion, and they might have increased anxiety in those situations, but not really identify that they have issues with the motion per se. And then you can also trigger dizziness, nausea, and issues with balance with peripheral motion. So with the peripheral vision, I mentioned that people kind of hyper focus on their central vision, and they don't become blind in their peripheral vision per se, but their brain really does not want to deal with all that extra stuff out there. It just wants to deal with a small amount of information as possible. And so think of it like, if I had a bunch of people yelling, over here, and you're trying really hard to focus on what I'm saying. It's not that you are just like, oh, I'm going to ignore them. That's fine. You have to really focus hard to shut out that information. And that's kind of what the brain does is it gets very tired and it gets symptomatic the more peripheral stuff is happening, even though it's trying to ignore it. So people again are going to have issues in those crowded environments. They'll say, driving is fine as long as there's not a lot of traffic. So increasing peripheral stimulus. And we've kind of talked about this a bunch of times before, but just to have an official slide for it, mismatches between the visual and vestibular systems. If you have some sort of inefficiency in the visual system, your vestibular system may or may not be affected by the TBI, but you are usually going to have symptoms that seem an awful lot like a vestibular issue because, again, any issue is going to create that lag between the two systems and it's going to cause a lot of issues. Okay, so just kind of taking a little step back and looking at what have we talked about here so far. So you have your physical integrity of the eye health, making sure all of that is fine. That's very important. That's the first step. Visual efficiency, that's the stuff that we're kind of just talking about with the binocular vision, saccades, pursuits, accommodation, and things like that. And then you have your visual information processing, which is all the nice stuff that our brain does after it's dealt with the basics of can I get their eyes to point, track, and focus appropriately and easily. And so visual information processing encompasses a good amount of things. So you have visual discrimination, the ability to tell two different objects or objects that are different from each other. Visual figure ground is often something that is very much impacted by a TBI. And so this picture right here is kind of showing a relatively cluttered garage that people with TBIs may have issues with because there's just so much stuff. And visual figure ground is essentially being able to separate the foreground from the background, or kind of like object identification. If I told you to go find the pink bicycle, it might be hard for that patient to find that because there's so many other things going on. Visual spatial relationships, this is your depth perception, and kind of where is something located in space, where are you located in space, and how do those things interact with each other. People who've had a TBI will often feel like they get turned around more easily. They might have more issues reading a map and getting oriented and things like that. And then some people may have some issues with kind of their rights and lefts and things like that, which is laterality and directionality. Visual memory. If your eyes are struggling with getting kind of a clear, stable image, and they're struggling with that visual efficiency of the binocular vision and things like that, your brain is going to have a harder time encoding that into memory storage. And so they're, again, going to have issues with looking at something and remembering it later. Visual closure, that is kind of your predictive visual abilities. So let's say, you've got someone wearing a mask and the bottom part of my face doesn't just disappear right here. And so you kind of know, or your brain is going to fill in what is probably down here. And, may or may not be correct, but that is visual closure. It's also involved in driving. So then I'm kind of predicting, if I am going here, what is going to happen if I, turn over to this angle or something like that. Visual motor integration. So again, your eyes are going to give your motor system information of how do I react to a stimulus. So if I'm looking something and I want to reach out and grab it, my brain needs to process, okay, where are her eyes pointing? Where is that object located, and what do I tell the hand, the arm to do to reach out for it? And so that's kind of involved with the depth perception and things like that, and spatial perception, all those sorts of things. Visual auditory integration. A lot of people will note down that it's harder for them to have conversations with people. It's harder for them to have eye contact. And so think of it as when you're looking at someone's face, it's a very intensive visual stimulus because we have, an entire area of our brain dedicated to just facial processing. And so our brain is trying to figure out, okay, what's the emotion here? What are they saying? And trying to integrate all of that. So a lot of people find that if I just look away and don't look at the person's face, I can listen a lot more easily. And so that's going to tell you that they have some issue with their vision that is impacting their ability to process auditory type of things. Okay, so then when would be a good time to refer your patients for testing? So let's say they come in, they have all these complaints and things like that. Maybe some of the older thoughts was that, just kind of wait and see. A lot of people recover within a couple months and things like that. There's a new research study that came out by the concussed group that essentially had two cohorts. They said, okay, these people just had a concussion. This half is going to do treatment right away. This half is going to just kind of wait and see how things go. And they found that the people who got treatment right away, resolved their conditions. And the people who waited, nothing really happened to them. They later on did treatment with them and they were able to resolve those issues. And so their conclusion was that, if you have people wait and they're kind of at the level of having all these symptoms, their likelihood of natural resolution is pretty low. And so you should probably just get them treated first thing if possible. And keeping in mind that vision is going to interrupt more than just the visual system. As we've kind of looked, it can have impacts on vestibular rehabilitation. It can have impacts on speech therapy, cognitive processing therapy, and things like that. And so they found that the visual system is going to really impact the cognitive effort because, again, the visual system takes up so much of your brain, about 40 to 50% of it. If the visual system is really struggling, it's going to draw away resources that you have for that nice cognition and things like that you might want to do. And so people are going to have that brain fog. They're going to just get tired more quickly, memory issues and things like that. And so they found that if you do rehabilitate the visual system, then those things start to improve more rapidly. Okay, so what do we actually do with these patients? We don't just, tell them what's wrong with them and say goodbye. So the first thing that I'm going to do is look at what can I do to get them relief the fastest and easiest, and usually that is some sort of way to modify how their brain is processing light. And so you can do occlusion, and the picture over on the right is examples of different types of occlusion we might do. So you have sectoral occlusion, where if they're having kind of constant double vision and prism won't fix it, just sticking a little tiny dot in the center can oftentimes work wonders. Sometimes we'll do occlusion, on the top or sides or something like that, depending on where they might have the double vision. Binasal occlusion, that's right in the middle of the glasses. And that one, think of it as reducing how much information their eyes have to process. You have your, each eye sees from here to here, and there's kind of that overlap in the middle. The binasal occlusion reduces the overlap that they have to deal with, and it also kind of forces them to be a little bit more peripheral versus central right here. Media occlusion, sometimes we do it just on one side and not the other. Different tints. We can do this by putting a tint, say, in their glasses, fit over lenses, sometimes just like a filter on top of their devices and things like that. We can also do more targeted light therapy with photobiomodulation to help the brain reprocess different things. You have therapeutic prisms. We can use this to help out with double vision, and we can use this to help out spatial distortions and things like that. And then changing the prescription, I had mentioned a bit before, is that I want to see if I can modify what the patient's doing. So my goal is not always clearest vision. I, of course, don't want to leave people with blurry vision because they'd never wear the glasses, but I want to see if I can just make it so their eyes are not working quite as hard. Sometimes they'll say your vision's going to be a little softer compared to your other glasses, but hopefully you'll feel better. And so these glasses are going to be guiding your eyes in the right direction. And then you have vision therapy. So this is training for the eyes to help them do all the things that I probably told them they're terrible at, and make it better for them. So we can train their accommodation as long as they, are kind of under the age of 40. We can train their eye tracking, pursuits, saccades, and fixation. We can train that convergence and divergence. Central peripheral processing is another very important part of therapy, visual motor integration and visual perceptual processing. And so for vision therapy, it is notoriously very long and uncomfortable for patients. So the faster we get to people, usually the faster therapy goes. If you think about, if you say break your leg or something like that, and the person still wants to keep walking on that leg, things are not really going to heal up very well for them. So with our eyes, if you first get an injury, you've got some issues going on with it. If the patient does not get treatment sooner rather than later, their brain is going to start compensating for stuff, and it's going to try as hard as it can to get those things to work. And so the more time since their injury is going to make it harder for us to do treatment, not impossible, but just it's going to add some time to their treatment because we have to go through and kind of pick apart any of those compensation mechanisms. And that oftentimes kind of leads to some discomfort for patients. And the most important thing for vision therapy with a TBI patient is that we want to get them to do these skills without symptoms. And so we could certainly plow through, get them in and out, and they can converge and diverge just fine, but they still have a lot of pain and discomfort with those skills. That's not what we need to do. So that's another reason why it goes slowly, because we need to get their brain doing those skills without activating all those pain receptors and kind of creating that discomfort for them. So let's see here. I think I have time for a quick case study here. This is CL. I initially saw them in January of 23. They had their injury about 2 years prior. With their glasses, I found that they did have a little bit too much prescription, causing their eyes to work harder. So I changed that and anticipated, probably going to be about a year and a half to 2 years of therapy is what I usually expect for most patients who have had that amount of time since their injury. Thankfully for this patient, they found that they had improvements at their first checkup after about 3 months of therapy, so that was nice. And they found that they had more stamina, less brain fog and things like that. They were able to get out and about more. Beforehand, they're kind of staying at home because they had too much stimulation when they were out in a larger environment. And they ended up graduating after about 59 sessions, so still not a short amount of time, but they had a pretty good result there. And these are kind of just highlights from their first and last exam. So when I first saw them, they had headaches after reading for about 5 minutes. Their MPC was reduced. Ideally, MPC should be about 1 to 2 inches from the nose or 5 to 7 centimeters. NRI-PRA is a test of essentially your focusing system flexibility. Distance, BO, and near BO, that's your distance and near convergence ranges. And that middle number um, should be around high 20s to 30s if possible. And then you can see at their last evaluation, after they had finished therapy for a little bit, they could go full day without symptoms with reading. Their MPC was to the nose, which is ideal, and they were able to do it 3 times, so no fatigue. Their NRA or PRA was in good range there, and their convergence ranges were also normalized. And so this patient is an author, and so that reading was really important to them. They had to stop working on the book that they're working on because they just couldn't really do anything for any length of time. After they finished therapy, they were able to finish up that book and publish it. And so, conclusions here, just remember that you really need to do extra testing or refer these patients out for extra testing. They may have gotten an eye exam at some point and are told your eyes are normal and fine, depending on the eye doctor. As with any practitioner, they may have more or less knowledge about issues with a TBI. So sometimes they will be told everything's fine, no issues. And so, don't worry about all those symptoms there. The other thing to remember is that most of those visual disorders that we talked about are going to have overlapping symptoms, and then some of them can also have overlapping signs like that receded MPC. And so you need to make sure that you're getting the testing done for the patients because treatment can be very different for them. And that treating those visual disorders can improve more than just the vision stuff. Again, there's lots of interaction with the vestibular system, auditory processing, and cognition for the patient. Okay, and here are my references and contact information.
Wonderful. Thank you so much, Dr. Doc, for sharing this wealth of knowledge with us today. Do you have a hard stop at 10 o'clock, or do you have a few minutes to take questions?
I have a few minutes, yeah.
Wonderful. And people can unmic if and go ahead and ask Dr. Doc questions. I've got a couple things that I'd sort of like to lay foundations with to ask you. One of them is very quick. Not everybody knows what suppression is in context
Mhm.
of double vision.
Okay,
I find
yeah.
the area fascinating because someone can it's sort of a hidden disorder in the sense that someone's not doesn't it's they're not consciously aware of it. So I think
Mhm.
it's almost like an agnosia where someone doesn't know what's going on with them health wise. So can you explain suppression in context of double vision?
Yeah, so suppression is that, if you have some sort of issue with your two eyes working together, your brain says, all right, let's just ignore the information from one eye. And it's not usually a conscious thing that's happening. It's not something that they can necessarily turn on and off per se. And it's oftentimes something that they're not even aware that they're doing. And so you see this most often in someone who's had strabismus, especially maybe like a long-standing strabismus. So I definitely see a lot of people who probably had some vision issues before their injury, and then the injury just aggravated that. And so if you see someone who, again, is not really complaining about a whole lot of vision stuff, they're not having blurry vision, they're not having double vision, but they have all those other things of maybe like light sensitivity, motion sensitivity, and things like that. They may potentially be suppressing. This is also important when, say, like you're doing your NPC, is that you're watching the patient's eyes. If you see one eye deviate, even though they didn't tell you that they saw double vision, that means that they're suppressing. And so you kind of, start to think about other stuff that they could be suppressing on.
Great. So that's the first question, and then I'll open it up for any other questions. Is there anybody else that has questions that would like to jump in? Laura, I
Hi,
think
this
you.
is.
Oh, go ahead,
uh,
Scott. Yeah.
Hey, yeah, I just had a quick question. I think your case study, first of all, it was a great presentation. Thank you.
Thank you.
But I think the case study said 84 sessions of treatment. Is that pretty typical, or what kind of range do you typically see?
Yeah, so for TBI patients, honestly, most of the time I'm not seeing people right after their injury, unfortunately, which is kind of why I had that big push of like, please send them. More time since their injury, I'd say most of the time I'm seeing people about like 6 months to a year after their initial injury because they've kind of gone through the ringer of all the different treatments before they end up to me. And most of the time, those patients are probably looking at about a year and a half to 2 years, is what I've seen for most of those patients. Vision therapy is works best if it's once a week because we really are working on not repetition for those visual skills. So I said, it's not about just getting them to those normal convergence and divergence ranges and things like that. It's about teaching their visual system, how do I do this properly and how do I do this without discomfort? And so that requires a lot of hand holding for patients. And we're also trying to make those really fine neurological changes for them. So, yeah, usually it's somewhere in that range of we see them a lot over the course of 1.5 to 2 years.
Great, thank you.
Mhm.
I think Laura is up next. Laura, go ahead.
Yeah, again, thank you for the presentation. And where were you 10 years ago when my daughter went through this, and 35 years ago when I went through this, and 2 weeks ago when my father went through this? So I'm just overwhelmed with the amount of information. My main question is, I know that when you go to an optometrist, they will do, like you say, the basic testing. Are optometrists generally able to then refer to neuro-optometrists, or how do you help someone, a patient or family member, get through that process convincingly?
Mhm.
Because I feel like you say, they're not looking for it, and even when you tell them someone's had a concussion, it
Mhm.
doesn't seem to be what they do.
Yeah, so that's kind of I think a general frustration in people who work with concussion with other practitioners who, not just optometrists, but other practitioners who are not necessarily aware of it. So, doing these lectures and things like that, trying to put the word out of like, hey, this is what to look out for. It really depends on the eye doctor that you go to on whether or not they're aware of this stuff. Like you said, you'll tell them these symptoms. They're kind of like, okay, don't know what to do with that. Don't know if that involves me or anything like that. And for some people, when they, maybe they do an NPC or they do a test of phorias, they're looking at your binocular vision. Sometimes if you're not really digging, it might look normal for some people, and they'll go, okay, I guess it's not this here. So if you don't know those symptoms to really look out for and say, okay, these symptoms mean they probably have some sort of issue. So I don't know if that's really answering your question there, but probably
Yeah. I guess
the
how many of these tests would be in the purview of someone who isn't a neuro-ophthalmologist, that if they expanded what they do, could they maybe pick up on more of this to be more confident with referring?
Yeah, so all of the tests that I do are things that every optometrist is pretty much trained to do. You know, technically speaking, in our training, we all learn how to do vergences, forias, things like that. But it's not something that is necessary to test in the general population. So, when I practiced general optometry, I didn't do this on every patient. And so it's more about that knowledge base of these are the things that people are going to tell me, and this is my next step here. And so again, it's more just kind of about awareness of them knowing. I have some wonderful doctors in the area that I work with a lot, and they are very much aware of, these patients have these things. I need to send them out if they're not able to, kind of do what they can. Some of these optometrists do know how to do really good work with prism. They know how to help them patients out with different tints and things like that, changing the prescription. And so there are a lot of things where if that general optometrist is trained and comfortable with it, they'll say, let's try this first. And then if that doesn't work, then we refer you out.
Okay, I guess last question quickly is there some sort of a one-page handout guide that kind of says, hey, concussion, maybe check for these things? Like, just because I feel like people do just fall back on just the regular exam and not look further.
There should be, I think, some guidelines. We have a kind of like the American Optometric Association. They have a section there for vision rehabilitation. I forget if they have kind of like a nice one-page summary, but I know that they do have some things of, awareness of like, let's look for this and things like that. So I can definitely look that up and see if there's something easy and that you can send out. I have my own little handouts and things like that, but coming from the AOA would be maybe more impactful through some people.
Awesome. Thank you very much.
Thank you.
A couple points, Lisa, maybe you can explain the additional credentials that you have and how that can be a qualifier for the public to understand that you have additional training. So the FOVDR, for example.
Yeah,
That's
so
something that I teach my patients. I mean, I know who to refer to in my area, but if they're in another state, I'll tell them don't go to a regular optometrist. Make sure they have this additional fellow.
yeah, so there's a an organization called they just changed their name, so it's the Optometric Vision and Rehabilitation Association, I think, OVDRA. And they are the ones who do the certifying. They do a lot of education for people who work in the neuro-optometry space. And so, generally speaking, you're going to want to look for someone who is a fellow of that organization. That means that they've gone through extra testing, training, and things like that, studying to make sure that they are up to the level that you'd expect for someone to understand these binocular vision issues.
Yeah, and it used to be, my recollection is it used to be FCVOD, and now I believe it's FOVDR.
Yeah, they
That
changed
used
it
to
because it
I
used to
talked to
be
Dr.
COVD, and with COVID hitting, that was kind of a big confusion for people. So,
I
yeah.
just put the acronym in the chat. So Lisa, that's something, and I don't know in Canada whether that applies or not. It probably does. It's probably
They do have a Canadian branch, and so generally you'll still look for people with those acronyms. Yeah.
and I would recommend, Lisa, go ahead and find somebody with that designation because trying to get a regular optometrist to suddenly remember things that they did in their core training and do it as well as someone that does it every day is not necessarily going to happen. And the other thing is, as Dr. Doc really emphasized, it's an integrated interpretation of tests. So, for example, I measure near point of convergence in my bedside neurological exam, but I never diagnose convergence insufficiency because, as Dr. Doc said, it doesn't mean that it just means the eyes are abnormal. And then if that's abnormal, I just document it as a reason for referral. So I think there's a few screening tests you can do if you're a doctor, like in general brain injury medicine practice, or you're in primary care and you know somebody's had a brain injury. But my referral, I mean, I refer a ton of people to neurooptometry, also to vestibular. I don't know if you have time today, Dr. Doc, to talk about sort of briefly and to sort of re-emphasize this sort of dual track of vestibular therapy and vestibular assessment, maybe in tandem with optometry, given the strong interconnections between the two systems. Can you sort of maybe reemphasize that and talk about that a little bit?
Sure. So I work with a lot of vestibular therapists, and so most of the time, patients are going to see vestibular therapy first. People are just a little bit more trained to send them to vestibular therapy. If you've got dizziness, it kind of makes sense you would go to vestibular therapy first. And so, most of the time, people are going to see that vestibular therapist first. They may or may not find something. The people that I work with are really good about like, okay, your vestibular system is fine with my testing, so go get your eyes checked. But for some people, you may be doing vestibular therapy and the patient is having a really bad time, or they're just plateauing. And so that's usually when you're going to think, okay, I should probably get their eyes checked out. And most of the time, I'll do the evaluation. I'll find something. If it's mild enough and the patient has, kind of mild symptoms, I'll try my best with the glasses to see, can I help them out? Some patients, they don't respond to glasses very well, or glasses changes and things like that. And so, if I'm able to find something that helps them out, and again, their visual findings are mild enough, I'll say finish up with vestibular therapy. If you still have issues, come back and we'll do the vision therapy. If their visual system is really bad, I'll say, okay, you're probably not actually making too much progress in vestibular therapy at this point because your visual system is really holding you back. And so if the vestibular therapist is able to work on vestibular stuff and they do have some issues there without involving the visual system too much, so not a lot of like gaze stabilization or anything like that, then they can do both in tandem. If they are kind of at the point where they've maxed out on all that stuff and now they're just at the point of integrating the visual and vestibular, I'll say, let's pause vestibular, let's go ahead and fix your eyes, and then you go back to vestibular to finish up, the other stuff that you need to work on.
Fantastic. So a lot of crosstalk and
Mm-hmm.
that's something that if you're not in the Seattle greater area where we have wonderful teams of brain injury specialists is to find out, if your neuro-optometrist coordinates and works closely with vestibular therapy, and so that that your patient's being taken care of in the way that many of our patients in the Seattle area are being taken care of. So well, Dr. Doc, I know you have a busy schedule. Thank you so much. This was a fantastic lecture. I know the students are soaking everything up, and have been asking for more and more lectures. We're going to take a hiatus for the holidays. And then I think the first lecture next year will be roughly January 23rd. And we'll be sending out notices for all the upcoming lectures in the winter and spring. And thanks everyone for joining. And thank you again, Dr. Doc, for taking time out of your busy schedule.
Yeah, thanks for having me.
Thank you so much. Bye-bye,
Thank you.
everybody, and happy holidays.
Happy holidays.